So now we're moving forward to the next session, which will be on myelitis. So, and I think there is some overlaps also in terms of questions. We have seen some of online that we will answer first. I'd like to start with the presentations as Albert did. So my name is Laura Cacciaguerra. I'm one of the autoimmune neurology fellows at Mayo Clinic. My background is that of a neurologist. I was trained in Italy, in Milan, and I have been doing my PhD in molecular medicine and then a postdoc research fellowship here in Mayo Clinic. And my co-chair here is Dr. Thakolwiboon.
So my name is Smathorn Thakolwiboon. So I'm originally from Thailand, and I went to medical school there in Bangkok, Thailand. And then I moved over here to the States for my residency. I did my residency in Lubbock, Texas, in the West Texas area. And then I did my multiple sclerosis fellowship at the University of Michigan in Ann Arbor. And then I did my autoimmune neurology fellowship here with Dr. Flanagan. And now I'm a neurologist. I'm practicing the Mayo Clinic Health System in La Crosse, Wisconsin, just across the Mississippi River, just on that border. And yeah, it's my pleasure to be here. And I think without further ado, we should start talking about myelitis. Yeah.
Yes, this is my understanding. So we were thinking maybe he has already covered that during his talk, but maybe we can just briefly summarize the key points of that. So the acute phase first.
Yeah, sure. So yeah, again, like spinal cord is like a highway that connects between our brain and the rest of the bodies. Informations go through there, like command from the brains and the feedback from the bodies, right? When we have acute attack, the MOG antibodies attack a myelin, or the surface of the highway, and also oligodendrocyte, which is a maintenance engineer of the highways. So this is why we have symptoms, but it depends on which highways got affected. Was it a sensory highway that got affected? We have sensory symptoms. Motor highway, that we have like motor symptoms like weakness, or it's affect like a bowel and bladder highway, the highway that connects bowel and bladder and brain, and that's when we have like bowel and bladder symptoms. And then next we can go.
Yes. Speaking of that, I just wanted, based on the comments we had online and also during the session, I think you covered that, but just to remember, so how can we differentiate in terms of symptom patterns between like a brain involvement or a spinal cord? So I guess like the bilateral issues, like when both legs are affected, when both arms are affected, this is something that points toward the spinal cord, while when there is more asymmetry, this could suggest that there is something going on in the brain. So most of the times, we would check probably for both, but just to have an idea of what is going on. And also probably regarding the timing of like from the very beginning of the symptom onset to the nadir, when there is something inflammatory going on, we would see like changes from normal to the worse over a few days. Okay, so especially when there is an acute attack. When we see something going on for like 1 month or super fast, like 12 hours, this is something that usually is not associated with this type of disease. So this is something also to keep in mind.
Yeah, I mean, that's a very good point. So timing is really important to diagnose this kind of like immune-mediated basis, like MOGAD, right? Timing is important. So it's usually progress like day to weeks, not like within few minutes or hours, or something's going on like months. It's not going to be like MOGAD. Yeah, in terms of symptoms, so let's talk about like motor symptoms. So the most common one is like a weakness, like we lose the weakness. And it's usually very severe when we're talking about like the attack nadir. A lot of patients need to be on wheelchair. A lot of patients need canes or walkers to walk. Yeah, but anyway, the recovery of the motor symptom is pretty good. And we will go over that later in the later like part of this talk as well. And the next one, I want to mention about like how sensory symptoms happens in MOGAD.
Oh yeah, so I think some of that was covered by Dr. Abuzaif. So bladder, bowel issues are very, very common during myelitis. So this is something that sometimes patients don't really bring up because it's a sensitive topic, but I would really encourage to like talk about that with your physician when this happens. First of all, for the diagnosis, because this is something very useful, like to think, oh, maybe there is something going on in the spinal cord. And second one, because there are many treatments that are available. Rehabilitation first, dietary changes first, and we will talk more about those later, but also rehabilitation, and urology can help too. So this is something that should be covered during the examination and during the history of the patient.
And next, about acute treatments. I know we're going to have like the whole big sessions later, but we can cover a little bit about that. So acute treatment, usually we need to treat as soon as possible. Time is spinal cord. It's very important to treat patient like early. We usually do with like start with steroids, and in severe case, we may do plasma exchange or IVIG together with the steroids. And then after that, you know, in MOGAD, it's very steroid dependent. So in many cases, we recommend a prolonged steroid tapering. In adult, we usually taper longer than 3 months. In pediatric scleroderma, gonna cover that later as well, but we're gonna do a shorter steroid tapering because the side effect can affect the growth of the kids as well. And do you have anything to add in terms of like treatments?
No, just if you wanted to mention, so Smathorn here had a very important study regarding the importance of plex. So how that can really, like adding an early plex can really help in terms of recovery. So this is something also that you may want to bring up, especially when the presentation is pretty severe. We don't really want to like waste time and wait. If the presentation is severe, like bringing up the possibility of an early plasma exchange is something that can be very, very valuable for the recovery.
And the important part of treatment, apart from immunotherapy, we need to treat symptoms appropriately, like Dr. Abdusef like mentioned like earlier. And and for patient with weakness, of course, physical therapy is the most important part in acute phase. But we want to do it as soon as the patient is medically stable. We don't want to force patient to walk and patient fall as well. And the other things that we need to worry in the acute phase setting is like we want to prevent patient from like complication of the symptoms as well. For example, with a bladder retention, the patient can have like UTI, so we need to prevent that as well. Patient with like motor dysfunction, we need to prevent fall as well, which can make clinical cause much more complex. And also side effect from the medication, we need to aware of that as well.
And once the acute phase has stabilized, the next step for sure is rehabilitation. So this is something that sometimes we oversee, but actually physical therapy, occupational therapy is extremely important and needs to be done like very, very early. So in the beginning, that's our golden hour to treat and to like go back to the motor patterns that comes with functionality. So this is something that should be continued probably for 6 months. Sometimes initially having a very intensive treatment with PT, for instance, twice per day for the first 2 weeks is something that really like helps and kicks in the beginning. Other things, also remember, I think that also for the bladder issues, there are rehabilitation programs. So there are some exercises that can be done by the patient at home, and they just need to be learned. And the MPT usually are really, really good with that. There are some stimulations that we can do. For instance, the peroneal nerves, which is just a nerve of the leg. This helps a lot with the bladder issues, and there are some providers, some PT who are very specialized in that. Usually they have a specific interest with the pelvic floor issues, and they are extremely helpful for the patient.
And for bladder, I mean, bladder from a spinal cord problem, it can be like 2 types. So the first one is bladder failure to empty the bladder, and the second one is failure to like store the urines. So and 2 different types have different like treatment kind of like strategy. Yep. Most of the time, we need to refer patient to urology, get a bladder scan to find out what type of bladder problem it is, and I mean, if it is like if the bladder is like too stiff or failure to retain the urines, we have some oral medication the patient can try. We can do like botulinum toxin injection, and we can do like a nerve stimulation, like the Cacciaguerra, like I mentioned about that. If the bladder is like too loose or is failure to empty the bladder, the treatment is more like physical therapy and also nerve stimulation. Yeah. But there are some like lifestyle change that we can do regardless of what type of like bladder symptoms it is. So first, we want to avoid irritants, for example, like caffeine, carbonated drinkings. We want to timing the fluid intake appropriately. We don't want to drink a lot of we don't want to drink a lot of water before we're gonna have a 1 hour drive. We have to time it like wisely. Yep, and again, Kegel exercise, the pelvic floor exercise is very important for like a bladder symptoms too. Yep, and for like bowel symptoms, it's quite complicated and it's very difficult to treat. If the patient has constipation, we may start with like increased fiber intake, some stool softener, but if the patient has like incontinence, that's quite complex to treat. So again, we avoid food that irritates the bowel, like fatty food or something that's very difficult to digest. Yep.
Yes. And now I think before we move on with the questions in the room, we had some questions online, so we will
address that first.
Yes. Give me a second.
So you have to read out from the computer.
This one here. Okay. All right. There were a few questions here. Let's see. Not all of them are about myelitis, but maybe we'll just should we just stick to the myelitis questions?
As you wish.
Sure.
Address that, yeah.
Dana asks, dysphagia seems to be something that comes up in the MOG groups. Is that more often brain or spinal cord, or is there a potential for both?
So I will take this because I know the answer. No, so this would be more brain, but not like the brain, the cerebrum that we have talked about in the morning. It is more the brainstem. So this is like a very ancient part of the brain, which is in direct connection with the spinal cord. And there we have all the centers that activate a correct swallowing. So dysphagia can happen if we have lesions there. So yeah, the answer would be the brainstem. So a part of the brain connected to the spinal cord, but it's a very complex symptoms, and the management can also be challenging. I would say the very first advice is do not eat something which is both liquid and solid. So for instance, oranges, these are something hard for like patients with dysphagia. Also the rice, especially when it's overcooked, so it becomes kind of sticky. This is also something very difficult. So always prefer like just one component, not too dry in case of solids. And then there are other things that you can look at. For instance, having a correct positioning of the neck. So one should start the swallowing in here, so in this position, and this helps. Also having something, eating something cold, this helps also, because we have other receptors that are susceptible to the temperature. So this is something that helps in patients with dysphagia. But yeah, I mean, we can give more information, but this is what I would say in case of this symptom.
Great. And another question from CJ, can you speak to the relation of intercostal muscle spasms, aka MS hugs, to MOG?
I mean, MS hug, it actually can happen in any kind of like spinal cord like problems. It's not necessarily MS, but we call it MS hug because it's described first in MS patients. If we have lesions in the area in thoracic spinal cord, it can cause an MS hug. it's gonna feel like a band around the chest. But when we have this kind of symptoms, so what we don't want to miss, we don't want to miss like heart attack, which can present with similar symptoms, and it is kind of like much more like life-threatening. So I think if we have these symptoms, so first we need to, like, if it's acute, we need to go to the ER, make sure this is not a kind of like heart attack, and after that we can treat it as like MS heart. The medication is usually involve medication like a gabapentin or muscle relaxants.
Great. And now we can open it up to the room. If anyone has questions, just raise your hand. I'll come over there.
Thank you. This is probably not related to myelitis, but when you were talking about dysphagia, it made me think of it. Almost every time he relapses, he gets hiccups. Very bad. So I don't know if you have any reason for that.
So this is actually interesting. So there is a specific area in the brainstem, which is called area postrema. And that area, when we have a lesion there, it can cause hiccups, like very severe hiccups. We see that more in another disease, which is neuromyelitis optica. But of course, if a lesion is there, regardless of the etiology, this is something that you can observe. So for sure, like, it's not the hiccups that we would have, I mean, in our everyday life. This is something more persistent, and it's actually a great observation. Yes, that can happen.
Hi, I have a question about myelitis and optic neuritis and whether they can be connected if they happen together or in quick succession. So my experience back in May, I had multiple symptoms of myelitis, then essentially got better on its own, and then in June got optic neuritis, and then got tested for MOGAD. Would those two incidents, if they're, you know, within a month or two of each other, could those be considered the same event, or are they distinct with different causes? If you have one, is the other more likely to happen shortly thereafter?
Yeah, this is a very good question. And amongst like the expert panel, we use a cut point of like 4 weeks or 1 month. When we're gonna call this is the same episode or like two distinct relapse. If you have like a myelitis at first and optic neuritis like 2 weeks after, we're gonna call it at the same relapse. But if let's say you have myelitis and then 8 weeks later you have another optic neuritis, we call this is a new relapse.
Yes, and also this association that you mentioned, this is something that that we see. So this is partially why MOGAD in the beginning was considered as seronegative, so no antibody, with no antibody because it was not known at the time, form of neuromyelitis optica, because we do see in some patients having a myelitis and an optic neuritis, like most of their attacks involving these two areas of the central nervous system. So this is something that can happen. The reason why there is this association is not really clarified, I would say, but for sure there is something there. So Dr. Chen was mentioning for the optic nerve that might have something to do with the types of barrier that we have. We have always thought that the central nervous system, so brain, optic nerve, and spinal cord, was something which is kind of which doesn't have much of an immune trafficking. So because we have this barrier between the blood and the tissue that helps for that. So if the spinal cord and the optic nerve have a sort of weaker, physiologically a weaker barrier, and so that's why the antibody cross. We don't really know this, but this might be an hypothesis. Or another thing could be that maybe the expression of the MOG, so the myelin oligodendrocyte glycoprotein, in those two areas is higher, for instance, than in the brain. We don't really know that. We have a lot of data regarding like gene expression in the brain, but I'm talking about like the brain, what we mean for brain. We don't have really much about the other areas of the central nervous system. But for this type of diseases, this is I think it's a new venue actually to explore more.